Welcome to our webinar, Ask the MDS Expert. Thank you for joining us today. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. It is possible that you may lose your connection during the program. Should you lose your connection and be unable to connect to the webinar online, you can call in to listen to the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. This is a question and answer webinar today, so there is no formal presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window, and when you finish typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert cannot answer any specific questions related to your personal health care. Our specialist today is Sandrine Niyongere, who is an assistant professor of medicine. Dr. Niyongere joined the School of Medicine in the Marlene Stewart Greenbaum Comprehensive Cancer Center in 2018. Her clinical focus is in acute leukemias, myelodysplastic syndromes, myeloproliferative neoplasms, and bone marrow failure syndromes. Her primary research interest involves finding new therapeutic targets by understanding signaling pathways involved in AML and MDS, as well as studying the role of the tumor microenvironment in the development of chemo resistance in leukemia. Dr. Niyongere serves as an attending physician on the inpatient leukemia service, training fellows, internal medicine residents, and medical students. Dr. Niyongere also serves on the Aplastic Anemia and MDS International Foundation on our Patient Education Council. It's my distinct privilege to welcome Dr. Niyongere. Thank you so much for joining us today.
Thank you so much for having me. It's such a pleasure to be here today.
Dr. Niyongere, what is MDS, and do we know what causes the disease?
Yeah, so myelodysplastic syndrome, it's a heterogeneous group of blood disorders, blood cancers with very distinct presentation. Myelodysplastic syndrome is characterized by ineffective ability for the bone marrow to make blood cells, leading to low blood counts. The medical term for that is cytopenias. And we know that in MDS, it carries a potential risk of progression to acute myeloid leukemia in a small portion of the patients. We really truly don't know what causes myelodysplastic syndrome. We know that patients who have had previous exposure to radiation or chemotherapy, they are at increased risk for MDS, but there are many patients who, don't have any glaring risk factors and still develop myelodysplastic syndrome. So we're still doing a lot of research to try to find out why people develop myelodysplastic syndrome. We know that there is an increased risk of myelodysplastic syndrome the older we get. And we know that there are specific DNA abnormalities, or what we call DNA mutations, that can increase your risk of developing myelodysplastic syndrome, but it's still an ongoing field of research that we're trying to better understand.
Thank you very much for that explanation. We have a question that says, is MDS genetic or hereditary?
That is a great question. There's a very small portion of patients who have these DNA abnormalities or DNA mutations that may have been inherited. We call them germline mutations. And these mutations may be passed down and can lead to, or can increase your risk of developing myelodysplastic syndrome. There are some, families where we have seen, increased number of family members with myelodysplastic syndrome and acute myeloid leukemia, and they have these specific mutations like RUNX1 or GATA mutations or other mutations, and we see that there's almost this familial myelodysplastic syndrome, but that's actually extremely, extremely rare. Most of our patients do not have a family history of myelodysplastic syndrome, and they still develop it. So the number of patients who have these familial, genetic mutations, they're very small in number and rare. A majority of patients do not have a family history of myelodysplastic syndrome.
Thank you. How is MDS diagnosed, and is the only way to diagnose through a bone marrow biopsy?
Yeah, a lot of patients, we first become suspicious of myelodysplastic syndrome when they are doing blood work and we see that they have low blood counts. So, a white blood cell count, on average, can be anywhere between like 4,000 to 10,000, and we see that their white blood cell count is low. We see that their hemoglobin and hematocrit is low. The medical term for that is they're anemic. And then we see that their platelets are low, and we call that thrombocytopenic. And so, a lot of our patients, they do blood work. Sometimes they have no symptoms. So it's just a routine physical exam, and they do blood work and they find that their blood counts are low, whether it's the white blood cell count, red blood cell count, platelet count, or any combination in between. And then that, typically sends, that primary care provider to start looking for reasons. Do they have iron deficiency anemia or B12 folate deficiency? And sometimes they'll do colonoscopies to see, are you losing blood to the GI tract? Eventually, our patients get referred to the hematologist because of the fact that they haven't found any other reason for their low white blood cell count, low hemoglobin, hematocrit, and platelets. And at that point, we need to do a bone marrow biopsy, especially if we see multiple abnormalities in your blood counts. And the reason is because your bone marrow, it's the factory that makes your blood cells. And the bone marrow makes your white blood cells, which is what helps you fight infection. Your bone marrow makes your red blood cells, which is measured by the hemoglobin and hematocrit, and that's what carries oxygen. And then your platelets is what helps you stop bleeding. And so when I see a patient and I see that they have a low white blood cell count, a low hemoglobin, or low platelets, I definitely consider doing a bone marrow biopsy. But if I see a patient who, let's say, has a combination of a low white blood cell count, and they have a low hemoglobin, or a low white blood cell count, or low platelets, or even worse, all three of those cell lines are low, then I definitely do a bone marrow biopsy, because that is the only way that I can truly rule out a bone marrow cancer. And so that bone marrow biopsy is really crucial for the diagnosis of myelodysplastic syndrome, because it's going to give us not only the confirmatory evidence of myelodysplastic syndrome, but it also gives us the information that we need to give patients prognosis. And most importantly, it helps us make treatment decisions.
Thank you so much. And how does further testing help with making treatment decisions? Like what is found in the tests that helps dictate treatment?
Yeah, so, the way we diagnose myelodysplastic syndrome is, one, the labs. So the initial labs with the low blood counts, tells us, okay, there's something going on with the bone marrow. And then once we do the bone marrow biopsy, the pathologists, have to look at the bone marrow, because as we said, myelodysplastic syndrome, it is characterized by ineffective ability to make blood cells. And so you have these cancer cells in your bone marrow that's preventing your bone marrow from making blood. And those cancer cells causes the cells in your bone marrow to look abnormal. We call this dysplasia. And so the pathologist is going to look at the bone marrow biopsy as well as the blood from the bone marrow, and they're going to look to see, one, we call that the morphology, or how the cells look in the bone marrow. And that's the piece number one that we need to make that diagnosis. If the pathologist see that we're seeing these abnormal looking cells in the bone marrow, or we call that dysplastic cells or dysplasia, these are abnormal looking cells. And specifically, we have to see more than 10% of the cells in the bone marrow, that percentage that are dysplastic. That again gives us that first proof that this is myelodysplastic syndrome. The bone marrow biopsy also allows us to identify the percentage of the cancer cells. Another name for the cancer cells that you see on the pathology report is blasts, BLASTs, blasts. Those are the cancer cells that are really crucial for helping us diagnose the myelodysplastic syndrome, because a lot of patients with myelodysplastic syndrome are going to have an abnormal number of these blasts or increased blasts. Myelodysplastic syndrome is characterized by less than 20% blasts in the bone marrow. If your blast in the bone marrow is greater than 20%, or you have these specific abnormalities, then we diagnose this as acute myeloid leukemia. So you can see that this bone marrow biopsy is crucial for differentiating whether patients have myelodysplastic syndrome or leukemia. So the bone marrow biopsy gives us information about whether we see these abnormal looking cells, that's the dysplasia. The bone marrow biopsy gives us information about the percentage of the cancer cells in the bone marrow, that's the blast. And then the bone marrow biopsy gives us an idea of how aggressive the disease is. And the way we get that information is from the abnormalities that leads to MDS. So DNA, those are the instructions that tell cells what to do. We have DNA in every cell of our body, and they are the instructions. They tell our cells what to do, how to function. The DNA, they're arranged in a structure called a chromosome. So DNA is arranged in a structure called chromosomes, and you get 23 chromosomes from mom, 23 chromosomes from dad, and they have a very distinct pattern and picture. Now with myelodysplastic syndrome, a large majority of patients are going to have chromosome abnormalities. And these chromosome abnormalities helps us make that diagnosis of MDS. They also help us make a decision on the prognosis, but they also help us with a treatment decision. And so the bone marrow biopsy is going to give us information about the chromosome abnormalities. Now, I will make a point that I have many patients who have a normal chromosome, and that is we see that in MDS, a normal chromosome, just as we see MDS patients with these abnormal chromosomes or damage to the chromosomes that are driving their myelodysplastic syndrome. And then the last piece of information that we get from the bone marrow biopsy is the mutations. And it's interesting how, as I've progressed in my career, as we've learned more about myelodysplastic syndrome, these DNA mutations have become much, much more important as we learn more information about these DNA mutations. And so these DNA mutations, we get that information from next generation sequencing, where we actually sequence the DNA in these cancer cells, and we look to see what are the abnormalities that have led to the myelodysplastic syndrome. And so all of that information is used by your hematology oncologist to, one, make that diagnosis of myelodysplastic syndrome, but they help when you have that discussion with your doctor about the prognosis. It helps us tell us how aggressive your disease is, what is your risk of transformation to acute myeloid leukemia, depending on what percentage of the blast, and then it helps us make treatment decisions because we're able to use that information to risk stratify you. And so a lot of patients are going to ask about that risk stratification, but we get all of that information from that bone marrow biopsy. And so you can see this this procedure, which can be very painful and uncomfortable sometimes. We're able to make that more comfortable by using anesthesia and local anesthesia so that it's much more comfortable. This procedure, though it's not the funnest procedure to go through, gives us so much information. That's why it's so important to have that bone marrow biopsy as part of the workup for myelodysplastic syndrome.
Thank you so much. How often should someone have testing done for looking into mutations? Can, mutations develop over time that may not have been present when a patient was first diagnosed?
The answer is yes. So I always do DNA mutation analysis at diagnosis. I want to see, where we are. And so the combination of those blast percentage with the chromosome abnormalities, with that dysplasia, along with the DNA mutations, we use that information to risk stratify patients into different groups. So we have lower risk MDS and we have higher risk MDS. That information helps me decide which patients need to go to transplant, which patients need to start chemotherapy, or which patients, I can just watch them. There are some MDS patients where we don't even need to do chemotherapy and we can just watch them because their blood counts, though low, are not at a point that they need transfusions. Now, over time, we oftentimes will repeat the bone marrow biopsy to see, are you responding to treatment if you're one of the patients who are on chemotherapy? Now, or sometimes, let's say you are doing really well on treatment, and then we start to notice that your blood counts are dropping, you're starting to need transfusions, we're worried that you're no longer responding to the treatment. Then we do a bone marrow biopsy to see, is your myelodysplastic syndrome changing? And so oftentimes we will see patients develop mutations that they did not have at diagnosis, and that will give an explanation for why they're no longer responding to treatment, because their MDS is evolving and changing, and that can help us make decisions on new treatments. And also, if you're a patient who initially we said you didn't need treatment, but now you're needing transfusions, we do a bone marrow biopsy and see you have these new mutations. These new mutations may tell us, okay, now it's time to start chemotherapy, and now it's time for you to meet with the bone marrow transplant doctors to talk about transplant. So absolutely, myelodysplastic syndrome is going to change over time. It's going to evolve. And one of the things we'll see is new DNA mutations that you didn't have at diagnosis. We can also see new chromosome abnormalities develop that you did not have at diagnosis. And the other thing we watch for is the blasts. Remember, those are those cancer cells. And so those blasts may be lower in number, but they can start to increase. And that tells us that we need to be more aggressive on the chemotherapy treatment. And that also tells us that you may be at risk of developing acute myeloid leukemia. And so that is where those DNA mutations can help, because it helps us identify that your disease is changing and evolving. So absolutely, yes, we can see patients develop mutations that they did not have at diagnosis, and that tells us that their disease is changing. That way we may need to start new chemotherapy treatments, and we may need to start talking to you very seriously about a bone marrow transplant.
Thank you. How is MDS classified, and what do those classifications tell a physician and a patient?
Yes. So, the thing about MDS I talked about is very heterogeneous, meaning that we can have very different presentation. I can have a patient with low white blood cell, low hemoglobin, low platelets. They're needing blood and platelet transfusions every week, and they have MDS, right? And then I have another patient who does not need blood transfusions. Yes, their blood counts are a little bit low, but not enough, and they're working full time and they're not having any symptoms. And so in a disease where you can have someone who's needing blood transfusions 2 to 3 times a week versus someone who's never had blood transfusions, but their bone marrow says they both have MDS, we need a way to decide which patient needs treatment and which patient doesn't. And so many of our hematologists and oncologists who focus on MDS across the world has done research. We have pooled all our MDS patients and monitored them over time. And what we found is that there are certain characteristics that tells us that a patient's going to have a more aggressive disease. One, most of our patients who tend to be older tend to have a more aggressive disease. Patients who have these specific chromosome abnormalities are going to have a more aggressive disease, or patients who have several chromosome abnormalities. If you have 3 or more chromosome abnormalities in your bone marrow and your chromosome analysis or cytogenetics, we call that complex karyotype, and that's associated with a more aggressive disease. And then patients who have specific mutations, some of these mutations you may have heard of, like TP53, ASXL1. These mutations tend to mean that your MDS is more aggressive. It doesn't always respond well to treatments, and it has a high risk of relapse. And so we have taken all of that information, the DNA mutations, the blast percentage, do you need transfusions? How low is your hemoglobin? How low is your platelets? And we have created these classification systems, and we call that the International Prognostic System, or the IPSS. And so the IPSS is an international measurement. It's a risk stratifying that we use to tell us which patient is more likely to have a worse prognosis. So that's called the International Prognostic Scoring System, or IPSS. And now we have an International Prognostic Scoring System that's been revised, where we've added more information so that we can have a better way of identifying which patient needs treatment. And so this international scoring, these IPSS classification system, it divides, patients into low risk, intermediates. We have this intermediate 1, intermediate 2, high risk, and very high risk. And so these groups tells us which patients need treatment. So in a patient who has low risk MDS, these patients, I do things to try to improve on their blood counts and their symptoms, but oftentimes I don't need to have them see the transplant doctor, versus a patient who has a higher risk MDS. These are patients who need chemotherapy treatment immediately. And these are patients who, if they're eligible for a bone marrow transplant, I immediately have them meet with the bone marrow transplant team. So the International Prognostic Scoring System and the revised International Prognostic Scoring System uses the information from the bone marrow biopsy as well as your lab results to put you into a risk group. And that risk group helps physicians, along with you, decide whether we need to start treatment now or can we wait, whether you need to talk about a bone marrow transplant or not. And the risk groups, we have these IPSS scores is a score that we assess at the time of diagnosis. And that score stays the same no matter what, because it's your score from diagnosis. We have other scoring systems that we use at different stages. Every time you have blood work, every time you have a bone marrow, we call that, it's dynamic. And we assess that, and that allows us to see how you're changing. So you could be low risk by International Prognostic Scoring System, but using these other risk stratifying calculations, these models, then we can see that maybe you're now becoming more higher risk and we need to change our treatment. And so you can see how that lab results along with your bone marrow biopsy results really helps us make that treatment decision, because we're able to use that information to risk stratify you, and based off of that group, make a decision on treatment. And then we can use other models to see how you're changing, how you're evolving, and that way we can change our treatment strategy.
Thank you. And this question reads, I was diagnosed low risk 4 years ago with MDS, and I've been watching weight. I understand that I'm not in the high risk group, and therefore not at risk for AML. However, I'd like to know, can a low risk patient go on to develop AML?
That is a very good question. And it's a fear that many of my patients have, because we know that when myelodysplastic syndrome transforms to acute myeloid leukemia, it becomes very aggressive. And so, the answer is that any patient with myelodysplastic syndrome has the potential to transform to acute myeloid leukemia, though we know that patients in the lower risk group typically have a lower risk or a lower potential or a chance of progressing to acute myeloid leukemia because of the characteristics that puts you in that low risk group. But the answer is that you're right, that potentially any patient can transform to acute myeloid leukemia. Now, we know that there are specific risk factors that increases your risk of transformation to acute myeloid leukemia, such as older age, the percentage of blasts in your bone marrow. So if you're someone with a higher percentage of blasts in your bone marrow, you are at increased risk of transforming to acute myeloid leukemia. And if you have specific mutations, an example is that TP53 mutation puts you at a higher risk of transformation to acute myeloid leukemia in some patients. And then patients who have distinct chromosome abnormalities. We talked about the complex karyotype, which are patients who have 3 or more chromosome abnormalities, which increases their risk of transformation. But ultimately, we really, we know there's certain, characteristics that we see in patients who transform to acute myeloid leukemia, but we still haven't pieced together exactly which patient is going to transform to acute myeloid leukemia. And a lot of research is being done to try to identify that. But what we do know is that the lower the risk you are, if you're someone who is in that good risk group or the very good risk group, these patients tend to have a lower chance or potential of transforming to acute myeloid leukemia, though that chance is never completely zero.
Thank you. Our next question is regarding blood transfusions. This comes from a patient who is almost 3 years out from diagnosis, and they've been doing relatively well, they say, with their MDS and needing transfusions maybe every 2 to 3 months. They'd like to know, how long can someone live on blood transfusions, and what is considered transfusion dependent?
Yeah, that's a great question. Depending on what clinical trial, we have a different definition of what transfusion dependent is. And so I always say that if any patient who is needing transfusions periodically, I say that they are transfusion dependent, because if they did not get those transfusions, their blood counts would eventually become seriously low. It is very good to see that you're not needing blood transfusions very frequently, which I do have some patients who are like that. There are some clinical trials who say that if you're needing, blood transfusions, every month or every couple of weeks. So that definition, it really changes depending on, that physician, or if you're being evaluated for a clinical trial, they will have their own, cutoffs for transfusion dependency. The question about how long can you go with transfusions, we have patients who can, be on blood transfusions for years. The important thing is making sure that we're monitoring your iron levels, because, the frequency of blood transfusions, every time you're getting a blood transfusion, a red blood cell transfusion, you're also getting iron. And so over time, that iron could build up, especially if you're needing blood transfusions very frequently. So for a lot of our patients who are getting transfusions very frequently, and we monitor their ferritin, and if your ferritin reaches a certain level, we will start talking about putting you on a medication to help remove that iron you're getting with the transfusions, so that you're not having any of that organ damage. And so that's what we're watching for when we're doing blood transfusions, is one, making sure you're getting the correct blood transfusion. So every time you're getting a blood transfusion, we do the blood test to make sure we have the specific type of blood that you need and that we're giving you the right blood. And then we're watching your symptoms to make sure that you're doing well with the blood transfusion. And then the third part is we're monitoring the ferritin, which is the lab test that tells us how much, iron is building in your body. And if you reach a certain ferritin level, we will start treatment to try to help remove the iron that you get whenever you get a blood transfusion. We call it iron chelation therapy. So for a lot of our patients who are just getting blood transfusions periodically, we're watching their ferritin. And if needed, we put you on that iron chelation to remove that excess iron so that we're not causing any potential damage to your organs, such as your liver and heart, because of the buildup of the iron. But otherwise, we have patients who can live for a very long time just getting the blood transfusions, years just getting, the blood transfusions.
Thank you so much. With all of the medications that are now approved for MDS, how does a doctor and a patient decide which of the treatment options are best for them?
Yes. So, the bone marrow biopsy with your labs and symptoms really helps us because we use that information to then do the risk stratification so that we classify you into a specific group. And so, typically, depending on what scoring system, most of the doctors are using the revised international prognostic scoring system or the international prognostic scoring system, but know that there are many different scoring modules. We have, many different scoring modules that has been created and validated across the world that you can use to help risk stratify you and put you in that risk group. Once we have that risk group, along with your symptoms and your labs, then we can make a decision on which treatment. So let's say you're someone who, yes, your blood counts are low, but you're not needing blood transfusions. Your results show that you're in that low risk group, then we may do nothing at all. And we just watch you. We call it close monitoring or surveillance. And I have patients who have been in this, this place for several years doing fine. But let's say you're a patient who the only issue is with your labs is you're just a little bit anemic and almost to the point that you're needing a blood transfusion here or there. And so if you're in that lower risk group, but you're anemic, there's a lot of different treatments. And we oftentimes, the first thing we go to is the erythropoietin stimulating agent. Those are the injections to help boost your blood levels. You can do that weekly or every 2 weeks. Where you come get those injections to help boost the blood so that you're not needing blood transfusions. That is an option. Now, I have some patients who, after a couple of months or a year or two on that erythropoietin stimulating agent, it eventually stops working and they're starting to need blood transfusions. Then there's other treatments that we can do to help, and so there's many different drugs that we have now, such as, lenalidomide or luspatercept. If you have that type of MDS called MDS with ring sideroblasts and you're needing transfusions. So, we really focus our treatment on the main symptoms that you're having, whether it's anemia or you're having low platelets. And then if you are in that higher risk group, those patients, especially if you're having low blood counts and you're needing transfusions, Vidasa or azacitidine has become the mainstay of treatment in patients who are in that higher risk group. Now, if you are someone who are in that higher risk group and you are eligible for a clinical trial, I oftentimes will try to put my patients who are in that higher risk group in clinical trials because, despite the new drugs that we have, we still have a long way to go with myelodysplastic syndrome. For all these new drugs that we've gotten approved, only a portion of the patients are actually going to respond. So if you're in that higher risk group and you're eligible for a trial, I do try to put my patients on a trial. Otherwise, azacitidine for my higher risk patients is my go-to. And then at the patients, when I'm seeing patient, I'm always looking to see, are you a candidate for transplant? And if you are a candidate for transplant and we have a potential donors, then I have you see the bone marrow transplant doctor. So kind of to summarize, your lab results with your symptoms, along with your bone marrow biopsy results, we take all that information, use those risk stratifying modules to put you in that risk group. And then based off of that risk group and the symptoms that you're having, we come up with a plan. If you're needing transfusions, we do the transfusions that you need, and then we try to improve, maybe try to give you a treatment so that you're no longer needing transfusions, such as the erythropoietin stimulating agent. If your bone marrow biopsy shows that you have this chromosome abnormality called deletion 5q, MDS, then we will do ESAs and then try lenalidomide, which has shown to be very effective in patients who have that deletion 5q chromosome abnormalities. If you have that myelodysplastic syndrome with ring sideroblasts, we have that new drug luspatercept. So that bone marrow biopsy results with the symptoms in your labs really help us make the decision on which treatment. And then ultimately, we're always trying to assess, are you a candidate for transplant? Are you someone who would benefit from a transplant. And if you have that higher risk MDS, you're in that higher risk MDS group, that intermediate to high risk, and you have these, characteristics that makes me worry that you have a more high risk MDS, then of course I'm going to start trying to determine, are you eligible for a transplant?
Thank you. For patients who are currently using Dacogen, is there any benefit to a patient to consider switching to Inqovi?
Oh, repeat that question one more time.
If a patient is currently using Dacogen, is there a benefit to them switching to the oral formulation Inqovi?
Okay. Yes, that's a great question. So, the oral decitabine was just approved, I think 2020, and it's super exciting because, now we have this oral, chemotherapy. And so I think that's a great conversation for you to have with your oncologist, with the hematologist oncologist about, the benefit of switching to the oral decitabine. Would you be someone who would be a candidate for it and you would do well, and we'd be able to monitor you closely? Because what the study showed was that the oral decitabine, it was, non-inferior to the intravenous decitabine. And so it is, I think that's a potential conversation that would be safe to have. If the question is, if you've done really well on the IV decitabine, do you want to rock the boat? Are you okay with rocking the boat and switching to the oral? And then making sure that you're going to be able to have that close monitoring, making sure you're aware of the difference in side effects between the two, and that you and your local oncologist feel comfortable with making that switch to that oral decitabine. But it is FDA approved for myelodysplastic syndrome, and the studies did show that it is non-inferior to the intravenous decitabine.
Thank you so much for that answer. When considering transplant, is there an age limit for patients to look at a transplant, and what other things are looked at to determine whether a patient is eligible for a transplant?
Yeah, so the age cutoff really depends on what transplant center you are at. So there are specific transplant centers that have very, strict age cutoffs. But what we're starting to see is that, it really isn't your age per se, but it's more the medical problems that you have along with your age. So, a person who is a certain age but has no other medical problems is completely different from someone who is that same age, but they have a history of heart attack, stroke, they have some kidney disease, they have some liver disease. So, in order for you to be eligible for a transplant, you really have to have a healthy heart and lung, normal kidneys and normal liver function. And then you also have to meet those criteria for that transplant health-wise. You're going to go through a very, systemic process and evaluation where they evaluate you from head to toe, looking at your heart, lung, kidney, liver function. They're going to ask you about whether you have a history of smoking, and they'll do, pulmonary function tests to see how your lungs are functioning. They are going to have you see the infectious disease doctor to have to come up with an infectious disease plan. A lot of transplant centers are going to have you meet with the psychiatrist and psychologist because this is a very, challenging and difficult process to undergo. They'll have you meet with the dentist. And then a lot of transplant are going to make sure that you've been compliant with their treatment, and they're going to look to see, your disease. So they're going to go over your bone marrow biopsy results. They're going to go over your labs. They're going to make sure you're someone who's going to benefit from a transplant. And then they're also going to make sure you have a donor, because in order for you to undergo a bone marrow transplant, you have to have a donor. You have to have, someone who, is a close match to you. And, for a lot of people, outside of age, the availability of a donor, could sometimes make people ineligible for a transplant if you don't have a donor, meaning you don't have a family member who's a close match. Remember, siblings have the highest potential. Siblings from the same mom and dad have the highest potential to being a close match. And then we go to the registry. Unfortunately, there are certain people, certain populations that are underrepresented in our bone marrow transplant registry, which makes it difficult for them to find a donor. Now, with us doing haplo transplants in myelodysplastic syndrome, we've actually increased the number of donors. And there are some patients who've been able to do cord blood transplants, though it's a lot rarer than in children. So finding a donor is that last piece, an important piece. We can't proceed with transplant without that donor. And so, they're going to look at a lot of different factors that is completely separate from age to make sure you're eligible for a donor. So what we're seeing is that they're learning how to, we are getting so much better at doing transplants that we're able to safely get patients through transplant. Because remember that there's a lot of morbidity and there is morbidity and mortality with a bone marrow transplant. So we have to make sure that you are as healthy as possible so that you can do well with the transplant. And that in age, it does factor in, but it's not the be all end all. And so now what we have this type of transplant called reduced intensity conditioning transplants. And so with these reduced intensity conditioning transplant, we're actually able to get patients who were previously excluded due to age. So, the answer is there are some transplant centers that have age cutoffs that are very strict, but there is a lot more. There are transplant centers that do not have strict age cutoffs. Instead, they look at your comorbidities. Is there a donor? Can they safely do a reduced intensity conditioning? And then they look at your organ function to make sure that you're eligible for a transplant. So age is only one of many different factors that they look at to see if you're eligible for a transplant. And that means that more patients, including older patients, are now eligible for transplant when they previously were not, which is, changing the way we're seeing and treating myelodysplastic syndrome.
Thank you so much. This question comes from a patient who is experiencing fatigue, and the fatigue happens in between transfusions. Any tips that you give your patients to help with the fatigue?
Yes, I tell my patients that fatigue, especially between transfusions, is very common. You have the best energy after transfusions, and then your lowest energy is probably right before your next transfusion. So I tell patients to rest when you are tired, which is very intuitive. Get that rest. Don't feel bad if you need to take that rest for the little bit. Let your body build back that energy, and then you can get up and be active again. When you are able to be active, try to be active. Do short walks because because that will help with fatigue. One, make sure you're when you have that energy, do the walks, stay active. But when you feel tired, go ahead and get rest. Make sure you're getting plenty at rest at night. Make sure you're following a well-balanced diet and drinking, plenty of fluids and staying hydrated. And then if the fatigue is still pretty severe, go ahead and have that conversation with your hematology oncologist, because it may be that we need to change your regimen. If you're someone who is doing transfusions, let's say every 4 weeks, let's take a look at your labs. Maybe it might help if we change and do transfusions every 3 weeks. And so, that it's important to have that open dialogue with your hematology oncologist so that we can change around your blood transfusions and allow you to, be at your best for as long as possible. Because ultimately, everything we're trying to do is to improve your symptoms and make you feel as best as possible. Because it may be that we need to do transfusions more frequently, or maybe this is the time to add a new treatment to see if we can improve your numbers so that you're not needing transfusions, as frequently. So if you're someone who is not on treatment, this may be the time to look to see if maybe an erythropoietin stimulating agent or another treatment may help with your anemia and your frequency of blood transfusions. So that open dialogue with your hematology oncologist is super important.
Thank you. We're in the midst of flu season. What are the general recommendations for patients regarding receiving the flu shot? And then on top of that, now we're looking at another booster for COVID. So how do all of these things end up together, being that they're happening at the same time? Is it safe for patients to receive all of these different vaccinations together?
Yeah, because of, I will say this, that I always recommend the flu vaccine for my myelodysplastic syndrome patients. It's so important. The flu vaccine is absolutely safe for our myelodysplastic syndrome, even if your blood counts are low, and it can really help with the severity of symptoms. Right now I'm having all of my patients get their flu vaccine, especially this year, because we're already starting to see a lot of respiratory viruses floating around in our community. My pediatric colleagues are telling me every day how bad the pediatric community is. Many of our school children are getting hit by these respiratory viruses. They're telling me about RSV and all of the other viruses. If we're seeing it in our pediatric population, we're going to see it in our adult population, and we're already starting to see flu. So I'm telling everyone to go ahead and get their flu vaccine. Now for our COVID-19 booster, I strongly recommend the COVID-19 booster, and I've been able to safely give it to my myelodysplastic syndrome patients. Just for my myelodysplastic syndrome patients who are on chemotherapy, I don't know how well of a immune response that they're having, but we are doing the COVID-19 boosters. And then for patients who are on active chemotherapy, I have been doing the monoclonal antibody. I'm kind of blanking. I am having them do, I'm just blanking. I am having them do some of the monoclonal COVID, the long-acting monoclonal injection for my COVID-19 patients. I am just blanking right now. It's a single dose. Why am I blanking? But that is what I've been doing, is doing that long-acting monoclonal antibody for my patients who are on chemotherapy. I bet as soon as I get off this webinar with you, it's going to come at me immediately. So answer is yes, I am absolutely having patients do the flu vaccine. It's super important. And I am having my patients doing COVID-19. I don't always do it at the same time, a lot of times because of side effects, but I've done it to where we were doing it, 2 or 3 weeks apart. But I've had patients who have did their COVID-19 vaccines and their flu vaccines back to back, and they did okay. Just some symptoms. I've had some patients who had some fever, had some patients who had some body aches and pains, and as soon as a couple of days, their symptoms got much better. And then the last part, like I said, if they are testing positive for COVID-19, I have been doing some of the over-the-counter antibodies, depending on if they're on chemotherapy or not.
Thank you so much. This question is in regards to bone marrow biopsies. How often should a patient have a bone marrow biopsy, and what would be the reason to have more than one biopsy? They are painful.
Yes, they are. Oh, and then just quickly, the long-acting, I've been giving my patients Evusheld. So that's something too, that's the long-acting monoclonal antibody for my patients who are on chemotherapy. They've been doing the Evusheld. Now, the question about the bone marrow biopsies, all of my patients have a bone marrow biopsy at diagnosis. And then we do bone marrow biopsies for my chemotherapy patients who have increased blasts, and I'm trying to see if they're responding to treatment, because the only way that I'm going to truly know is doing that bone marrow biopsy. So even though my patients had low blood counts, we started treatment and now their blood counts are normal, they're no longer needing transfusions, I will do a bone marrow biopsy to see, am I getting those blasts to decrease? Because remember that the increase in blasts increases your risk of transformation to leukemia. And so one of the things I want to see is I want to see that the degree of MDS in their bone marrow is disappearing. It's decreasing, or I'm no longer seeing it. I'm no longer seeing increase of those blasts, and that their chromosome abnormalities that we detected at diagnosis are disappearing. And then those DNA mutations that were detectable are also disappearing. And so we call that complete response. And specifically, I'm looking for a complete response or complete remission, and they're minimal residual disease negative, which tells me that they have had a very good response to treatment. Now, once I've done that bone marrow saying that they're in remission, they've had a very good response, I won't do another bone marrow until I start to see that their blood counts are dropping. They're starting to need transfusions. And then I will do a bone marrow biopsy to see, are they relapsing? Is the MDS coming back? Now, for my patients who are low risk, I only do a bone marrow biopsy if I'm thinking that their MDS is evolving or progressing. They're going from low risk to high risk, meaning their blood counts are rapidly changing, or I'm starting to see those blasts in the blood and I'm worried about them transforming to acute myeloid leukemia. So for my low risk patients, if their counts are stable, they're not needing transfusions, we're just watching them and they're doing great, I won't do a bone marrow biopsy until something changes and I'm starting to see that their counts are worsening or they're progressing. Now, for my patients who needs to go to transplant, I am trying to get them to transplant. We of course will do that bone marrow biopsy at diagnosis that tells me this is a patient that needs to go to transplant. I start treatment and then I do a bone marrow biopsy after the first cycle. Sometimes I'll wait till up to the fourth cycle, do that bone marrow biopsy to see, are they responding? And then if they're about to go to transplant, we oftentimes do a bone marrow biopsy right before transplant to get that baseline bone marrow biopsy, and then they'll do another bone marrow biopsy after transplant to see how well they responded. So you're right that we try not to do bone marrow biopsies very often because you're absolutely correct. They are painful. So we try to limit these bone marrow biopsies as much as we can. Now, I will say that if you're on a clinical trial, the clinical trial will designate specific bone marrow biopsies at these time points. And sometimes it's really hard to change those bone marrow biopsies. So when you're looking at a clinical trial as a patient and trying to decide if I want to do that clinical trial, an important question to ask is, how frequent do I need to do the bone marrow biopsies? And can you skip some of these bone marrows? How important are they? So that you can make an informed decision about doing a clinical trial, because typically patients on clinical trials tend to need to do more bone marrow biopsies than patients who are not on clinical trial. I don't want that to be something that scares you from a clinical trial, but I want you to be aware that if you are on a clinical trial, you may need to do a little bit more bone marrow biopsies than you normally would.
Thank you so much. Speaking of clinical trials, are clinical trials only for patients where other treatments have failed them?
Yeah, the answer is no. We are trying to improve on our knowledge and treatment of myelodysplastic syndrome at all stages. So, we oftentimes think of clinical trials in patients who are not responding to treatment, but we actually do clinical trials to find out what is the best initial treatment for myelodysplastic syndrome. So if you look at the clinicaltrials.gov website and type in myelodysplastic syndrome, you're going to see that there's clinical trials for patients who have low risk disease to see what is the best way to manage low risk disease. There's clinical trials for patients who have anemia or patients who have low platelets. And then there's clinical trials for patients who have never received treatments for myelodysplastic syndrome, and they have higher risk disease. azacitidine is our go-to drug for patients with high risk disease, but we're trying to see that if we add additional drugs, can we improve on the response? So there's a lot of trials looking at hypomethylating agent plus a clinical trial drug to see if we can boost the number of patients who respond to treatment. So there's clinical trials for patients who've never received treatment. There's clinical trials for patients who've never received the hypomethylating agents, and there's clinical trials for patients who have low risk, as well as for clinical trials for patients who have received treatment and they're no longer responding to treatment. And so, it's amazing that we're able to do these trials, because each time we do this trial, we're getting more information on the best way to treat myelodysplastic syndrome. So there's clinical trials for all parts of the phases of myelodysplastic syndrome treatment.
Can a patient who enrolls in a clinical trial stop their participation at any time during the trial if they no longer feel comfortable participating?
Absolutely. And that's something that we stress to our patients who are thinking about joining a clinical trial, is the fact that you can stop that clinical trial at any moment, and it's not going to, be counted against you. So you can always withdraw from the trial at any moment. And we will, help you safely get off of that clinical trial and find you another treatment that you're more comfortable with. And so that's the benefit of clinical trial, of the fact that you can absolutely withdraw at any time, and then your physician's will help you find another treatment or another option.
How are clinical trials made safe for patients?
Yeah, before we open a clinical trial, so many people are going to look at that clinical trial to make sure it's safe. So at each institution, there is a scientific review committee that looks at the trial to make sure, does this make sense, scientific sense? Are we actually going to, if the purpose of that trial is to see if drug A is better than drug B, have they designed this trial to actually find that information while keeping patients safe? After the scientific review committee, it goes to the institutional review board. The institutional review board is made up of not just doctors and nurses, but also pharmacists, and then people in the community. So we have, teachers, accountants, previous patients, caregivers, on institutional review boards. We have librarians. We just have people from every job and occupation in the community, because we need not just doctors and nurses and scientists looking at the trials, but just people in the community who are going to just use their knowledge and background to say, does this make sense? Are we keeping people safe? Are we keeping our patients safe? Have we thought of all of the downside of this trial? Are we making sure that this trial is convenient for patients? And then we have different, government boards. So the Food and Drug Administration, the FDA, they, look at all of the trials, and they're going to look at the trial from the beginning before it even goes to the, the community. They're going to look at the drug. You have to do preclinical studies in the laboratory. And we have to give that information to the FDA, and they decide if this drug can even be used for a clinical trial. And then the FDA has to approve the clinical trial. The clinical trial oftentimes have a safety committee that, once the trial starts, they review every data from every patient on the trial, and they are going to stop the trial if there's any signs or evidence that this trial is unsafe, or if we have answered the question and we don't need to expose patients to an inferior treatment. And again, like I said, the FDA is always monitoring the trials and doing interim analysis along with the IRB. And then your physician, who is, there with you, along with the physician who is ahead of the trial, as well as the pharmaceutical company, they're also looking at the trial, looking at the data to make sure that patients are safe. So you can see that we have set up multiple different committees and groups of people from all walks of life to look at the trials, monitor patients on the trial, and make sure that these trials make sense, so that patients are safe and we're able to effectively do trials that gives us the information that we need in order to improve our knowledge and our treatments for these diseases.
Thank you so much, Dr. Niyongere, for sharing your time answering all of these wonderful questions over the last hour. Thank you so much for sharing your expertise with all of us today. And if you'd like to watch this webinar again at a later time, it will be available on our website within just a few business days. If you have any additional questions, please feel free to send it to us at any time in 3 ways. Email help@aamds.org, call our helpline at 800-747-2820, or you can submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 39 years. This concludes our program. Thank you again, Dr. Niyongere.
Thank you so much for the invitation.